just use the arrow keys.
Okay, perfect. Thank you. Hi, everyone. My name is Monica Hulbert. I'm a pediatric hematologist at Boston Children's Hospital, and it's really great to be here today and speak with all of you and talk about brain health, which is something that is really important to all of us. So I'm going to be talking about chronic transfusion therapy for brain protection in sickle cell disease, and specifically children. This has sort of been alluded to a few times through the talk, and hopefully I can answer some questions. So I'm briefly going to review specifically the brain complications that you've already heard about, but also how transfusion therapy, how we approach transfusion therapy for each of those things, and what we call chronic transfusion therapy. So this has already been reviewed by the excellent speakers ahead of me. Including the fact that the high risk of strokes and the abnormal TCDs and the silent strokes, we know the most about that in people with hemoglobin SS disease or S beta 0 thalassemia. And we've talked a lot about how the sickle cells get stuck in the blood vessels and cause damage. But one thing that, that is really important to understand, and why the SS, the individuals living with SS and S beta 0 thalassemia have the higher risk for these problems, is because of the severe anemia. So anemia means low number of red blood cells. And people with hemoglobin SS and S beta 0 thalassemia on average have the lowest hemoglobin of all the people living with sickle cell disease. And that anemia, in addition to the blood cells getting stuck in the blood vessels, really contributes to and causes a lot of these problems. When someone is really anemic, the amount of oxygen that they can deliver to their brain or any of their organs is reduced. And also their body is working much, much harder to get what blood they can up to their brain all the time. So the body has a lot of different adaptations to try to cope with that anemia, but there is a limit, and and that is a major part of many of these problems. Additionally, the arteries to the brain can become narrowed, a condition called moyamoya, which I believe one of the subsequent speakers is going to cover in more detail. And finally, anytime when you're already really anemic and any additional stress that happens to the body, like having acute chest syndrome where your oxygen levels drop, or having a fever where your heart has to pound harder than normal, those things can also contribute to the risk of making a stroke too. So overt strokes has already been covered quite a bit. So, historically, as was mentioned, about 10% of people with hemoglobin SS disease would have a stroke by age 20 years. And as Dr. McGann pointed out, these were people who were not on hydroxyurea, nor did they have the benefit of TCD screening. So fortunately, we're in a much different place in the world right now where we have much better tools for prevention. When somebody has a stroke acutely, so they come into the emergency room with those symptoms of a stroke, and we say, yes, this is consistent with a stroke. We might also get an imaging study that shows a stroke. We do immediately what's called an exchange transfusion, or we take out the sickle cells and we put in healthy blood. But following that, then we put patients on what we call chronic blood transfusion therapy for secondary prevention. That means after the first thing already happened. And we know that this reduces the risk of a recurrent stroke, but it doesn't prevent it completely. But it is considered to be the standard of care. And I put this link here if this is something that might be of interest, in a newspaper article that ran in the New York Times some years ago about a family in whom 2 children living with sickle cell disease experienced strokes, and talked about their treatment. We've also talked a little bit about transcranial Doppler stroke risk screening. And one of the things that I want to emphasize about this is the development of the TCD test was spurred by the recognition that so many children with sickle cell were having strokes, and we wanted to be able to have a tool to prevent those. So the TCD was developed to identify those kids before a stroke even happened so that we could make a change to their treatment and help keep the stroke from happening. And it's incredibly successful. Regular TCD screening of a population of individuals living with sickle cell disease, specifically SS and S beta 0 thal, reduces the stroke risk in that group by over 90%. And if you put them on blood transfusion therapy when we know that they are at high risk of having a stroke, that reduces that risk in those children by 90%. So it's a huge development to have this tool. And this is, it's very, very important. And this is still important to do even if you are on hydroxyurea and doing well. I guess in contrast to Dr. McGann, I have seen a few children, very rare, that were on hydroxyurea and still had an abnormal TCD. So I just want to emphasize that it's not either or, it's really both. And then we've also talked about silent cerebral infarcts, and these being the small stroke areas that don't cause obvious symptoms but can affect learning, that we can only detect on an MRI. And a large clinical trial that evaluated chronic blood transfusion therapy found that the risk of developing more silent strokes was a bit improved on chronic transfusion therapy. Again, this was compared to children who are not on hydroxyurea. So a little bit before our most current treatment recommendations. The data for this is a little bit less, is not quite as strong as for the TCDs and the strokes. So there's probably more that we can learn about that. But as mentioned, we do have a recommendation for the screening MRIs now because of this. I just wanted to show what the brain imaging might look like for somebody that's had a silent or overt stroke. So this is a brain MRI from a patient who had a silent stroke that we found kind of by accident. And shortly after this, this child had had a severe episode of acute chest syndrome, was in the intensive care unit. So these two little areas that are bright white on this particular brain scan represent silent strokes. They're very small, they're no symptoms, and they're in the area that we know silent strokes are more likely to happen. And then in contrast, this brain MRI is of a teenager who had had multiple obvious strokes where they came in with weakness, they had trouble talking, and you can see, and subsequently some kind of learning problems as well. And you can see that there are these like much larger areas that are abnormal, and there are many of them, and they're distributed throughout the brain. So I think sometimes it can be helpful to have a picture of what we're talking about when we're discussing these two different types of injuries. So how does blood transfusion or chronic blood transfusion therapy help? So as you can imagine, if we're giving a blood transfusion, if you start out with 100% sickle cells and we give blood that has no sickle cells, then we're diluting out some of the sickle cells. So it reduces the amount of sickle cells in the blood. It also improves the anemia, and how I mentioned that the anemia is such an important part of the risks to the brain in sickle cell disease. So I don't know if anybody's ever had like iron deficiency anemia, or when you feel really terrible when you have that, and when you get that corrected, you feel better. So the same thing kind of happens in the brain with sickle cell disease. When we improve the anemia, the brain feels better. And then in one of the ways that we know this, it reduces the stress on the brain that's related to blood flow and blood delivery. And this is a little bit complicated, but I wanted to show just a picture of what the brain looks like without, just kind of at baseline with no transfusion. So this is a child of probably about an 8 or 9-year-old who had a baseline screening brain MRI, and using a special technique where we could look at the blood flow and how fast is the blood flowing and how hard is the body working to remove oxygen from the blood to get into the brain. So this is at the baseline, and what you need to know about this is that the brighter yellow it is, the more stressed the brain is in that moment. So you can see that before the patient had gotten any blood transfusion, their brain is showing all of these areas that are bright yellow. The brain is working very hard and is experiencing a lot of stress. And then the patient also on this same day actually had an abnormal TCD, ended up going on to receive chronic blood transfusion therapy. And so about a year and a half later, while on the chronic blood transfusion therapy, then they had another MRI before and after their transfusion. So they went to the MRI scanner, they went to the clinic, got their transfusion, they went back to the scanner. So before the transfusion, there's less bright yellow areas compared to when the child was not getting any blood transfusions at all. Both the top line is blood flow and the bottom line is oxygen levels in the brain. And then you can see immediately after the transfusion, the bright yellow areas showing that stress in the brain are reduced even further. So this is just an example of how quickly a transfusion can help the brain and the amount of stress that it's experiencing. And you can see here too, the hemoglobin. So before any transfusions, the hemoglobin was 7.5, which is a pretty average amount for a patient with sickle cell disease that's not on any therapy. And then before the transfusion was 9.3 and after was 10.2. So there's a nice improvement from the transfusions. So hopefully this has been helped to explain why we feel that chronic transfusion therapy is so beneficial for children with sickle cell disease at risk of brain problems or who have already had a stroke. And I wanted to just mention a little bit about the process of doing the chronic transfusion therapy. So typically this is going to be something that's done in the clinic about every 4 weeks. And we adjust the frequency or the amount of time in between based on the blood levels, before and after transfusions. Our goal is to keep the hemoglobin S % less than 30 before the next transfusion. And so that does require doing this pretty often. And every month we monitor the hemoglobin S levels, the hemoglobin, of course, ferritin, which is a protein that tells us how much iron is stored up, and antibodies every month. When patients have received about a year's worth of transfusions, they often will need to start a medication to remove excess iron, because when we give the transfusion, iron builds up and then we have to figure out how to take it out because we don't have a natural way to get rid of iron. And then we also do monitoring, typically annually, at least after a couple of years, of the liver and the heart to make sure that the iron levels are remaining in a safe range and that our chelation medicine is effective. So transfusion therapy, like any medicine or treatment, requires us to balance the benefits and the risks. So on the risk side, we know that there's a chance of getting iron overload, making antibodies to the blood cells, having problems with needing to get an IV every month, because that can be kind of challenging. A lot of times people worry about the risks of getting an infection, like a viral infection from the blood. Fortunately, in this day and age, it's very, very low because of incredible technology advances that the blood banking sciences have made in preventing transfusion-associated infections. And then on the positive side, a lot of patients, we know that it reduces stroke risk because of the research that I mentioned. A lot of patients report that they have better energy and they feel like their quality of life is improved. And if patients have pain episodes periodically, some of them have fewer pain episodes when they're on chronic transfusions as well. So there are benefits, but the risks make it something that we can't say is right for everybody all of the time. So just to kind of summarize this, I wanted to, just mention how do we kind of approach this? And when we're talking to you or your child in the clinic, how are we going to think about this? So for all children with hemoglobin SS or S-beta 0 thalassemia, of course, the hydroxyurea, as Dr. McGann discussed, the annual TCD screening and the MRI screening. If the TCD is abnormal, we will start chronic transfusion therapy, typically for at least 2 years, and then we'll consider switching back to hydroxyurea based on a study that showed that for many patients that's safe and effective. If we do an MRI for screening purposes and it shows silent strokes, then we would have a conversation about whether chronic transfusion therapy is the right thing to do next. Like I said, the data on this are not as strong. And so it's not a slam dunk like the TCD is. It's not an obvious decision, but it's certainly a conversation to have. And then we would reassess the benefits and risks after about 2 years of therapy. And of course, if somebody does unfortunately have an overt stroke, which in childhood is much, much rarer now than it used to be, then long-term transfusion therapy is the standard of care, you know, and then, you know, potential, you know, that's kind of the standard to offer at this point. And then potentially curative therapy if that's appropriate for the patient. So that's kind of the summary of what I had for today. So I'm happy to take any questions later.